Our next presenter, who's Dr. Heffernan. Aaron is a registrar in intensive care medicine based at Logan Hospital. He is a real expert in PKPD, having done an outstanding PhD in the area, and has a project for his Advancing Queensland Clinician Research Fellowship based on the ROAD study, which is Resistant-Optimised Antimicrobial Dosing. Aaron.
Thanks, Jason. Afternoon, everyone. Thank you for hanging back. So I'm going to talk about the Resistant-Optimised Antimicrobial Dosing in Critically Ill Patients study, or ROAD study, that was performed here at the Royal. I don't need to tell anyone in this audience about the importance of antimicrobial resistance, and the trajectory that we're on is not ideal. As we know from the O'Neill report, AMR-related or antimicrobial resistant-related deaths are projected to increase. We already know that sepsis costs the Australian healthcare system over $600 million each year, of which these costs are projected to increase substantially in the context of trying to treat and prevent antibiotic-resistant infections. How antibiotic resistance happens, on a simplistic level, when patients are exposed to an antibiotic, it's well known that a certain subpopulation will likely have or develop intrinsic resistance to that antibiotic. When you expose the patient and those susceptible pathogens to a therapeutic exposure of the antibiotic, it allows these subpopulations to thrive and grow in an environment where there's less environmental pressure for nutrients and such. And that just allows the resistant subpopulations to thrive and grow. When we dose antibiotics conventionally, we look at trying, in particular beta-lactams, we try to aim for a time above the MIC, as you've heard from our previous presenters, whereby the concentration of the drug is sustained above the MIC throughout the dosing interval. Although this is associated with improved clinical outcomes from a clinical cure and a mortality perspective, as we had just discussed, it may not be enough to prevent the emergence of resistant pathogens. We know from clinical and in vitro studies, such as those conducted by Professor Landersdorfer, that an exposure of at least above fourfold the MIC, so fourfold that which we would normally look to target for clinical cure, is required to suppress the emergence of most resistant pathogens. And so that's in part what the pilot study of the ROAD was designed to look at. So the objectives for the ROAD study, being a smaller phase 1, was primarily safety and feasibility, whether or not we can do this in a safe and meaningful way for patient outcomes, to identify if there was any resistance emergence, as well as correlate the increased antibiotic exposure and the antibiotic dosing with clinical outcomes. So following patient enrollment of adults in the RBWH ICU, they were, this as being a single center, open label, non-randomized phase 1 study, as I said. These patients had their dose optimized using empiric projections based on IDODS, which was followed up with daily therapeutic drug monitoring, and incorporating those drug concentrations using Bayesian pharmacokinetic software, as we've previously heard of. Dosing variations were described and implemented thereafter. Patients, although you might think that we're targeting fourfold the usual amount, there were safety parameters put in place with regards to maximum exposures for each of the antibiotics used in the study, being piperacillin, tazobactam, and meropenem. Concurrently, microbiological diagnoses were undertaken as part of routine clinical care, as well as routine screening swabs to identify resistance from a screening perspective, but also from a clinical isolate perspective. The MIC was determined using either the E-test or the VITEC, and then dose optimization targeting that C-min to MIC ratio of greater than 4 was implemented for isolates where an MIC was known, or the UCAST clinical breakpoint for Pseudomonas, one of the more resistant bacteria, was used. The primary outcomes being that of resistance emergence during the course of the treatment, the safety, primarily neuro, nephro, or hepatotoxicity, as well as the clinical efficacy in terms of patient mortality and clinical cure rates, were identified as our primary objectives. Obviously, being a phase 1 study, we only enrolled 25 patients, 14 of which received piperacillin and tazobactam. As you can see, the Apache 2 score is representative of most in critically ill patients, primarily a medical diagnosis. Importantly, one patient had resistance emergence documented. This was in a patient who was colonized with a Pseudomonas aeruginosa. Initially was identified as having a an isolate susceptible to meropenem that was subsequently developed resistance. Importantly, this particular patient only achieved the target exposure after the colonization or after the emergence of this resistance. So this patient actually didn't receive an effective exposure prior to resistance being identified. Despite that, most other patients met the predefined PK/PD target at some point throughout the course of their treatment, most of whom, as we saw from Dr. Irwin's results previously, most of them achieved the PK/PD target within 1 day. As you would also expect, targeting a higher exposure, the dose was increased in 12 patients, but importantly, in 14 patients, the dosing regimen was changed to a continuous infusion to reflect what now reflects the results of the BLING study with the improved pharmacokinetic profile of those continuous infusions. There were no adverse effects related to the study drug. Obviously, being a critically unwell patient population, there were incidents of renal impairments and hepatotoxicity, but these were deemed unrelated to the study drug. And there was clinical resolution in 12 patients, once again reflecting the difficult to treat nature of these infections and the illness severity of these patients being in the intensive care unit. From a pharmacokinetic perspective, you can see that these results are actually quite similar to previous therapeutic drug monitoring studies, such as the Dolphin study that was released a couple of years ago, whereby patients, between 50 and 60% of patients had therapeutic exposures on day 1, which did fluctuate throughout the course of the treatment profile, meaning that it is quite difficult to predict what doses patients need in particular. And in the context of resistance suppression, higher doses are likely going to be needed above and beyond that which we've normally been happy to prescribe. Nonetheless, the take-home message from this phase 1 study is that we can dose these patients to achieve the predefined targets. It's likely safe and it's likely effective. And so now we'll await the ROAD RCT, which will hopefully be performed in conjunction with our proposed collaborating partners, such as Professor Yandawal from Ghent University and elsewhere throughout the world. So thank you very much, everyone.